Hi everyone, and welcome to Feedback Loop 2 for Western Sydney LHD Safe Haven. My name's Carrie. I'm a facilitator with Roses in the Ocean.
Hi, I'm Tina. I'm also a facilitator for co-design in Roses in the Ocean.
And so thanks, Tina, if we just share the slides.
Yeah.
Thanks. Just like to begin with some acknowledgements. Thanks, Tina. So we'd like to acknowledge all the lands on which we're meeting today in a virtual environment. That's many, but particularly to acknowledge that it's Darug country, and to acknowledge the Darug people of the Western Sydney region on which this safe haven is going to be established. And we acknowledge the traditional owners and custodians of these lands, and also to pay our respects to the elders, past Darug elders, present ones, and also those emerging leaders. Thanks, Tina. In the context of co-designing new suicide prevention services, we also like to acknowledge people with a lived experience, particularly also to acknowledge the uniquely valuable lives that we've lost to suicide, and to people who are still struggling with life today. And to acknowledge that people with lived experience that are here specifically for that expertise to participate in this co-design initiative. It's really fantastic to have them involved, but also to acknowledge that health professionals, particularly ones that get involved in these processes, have their own lived experience, if not personally, then certainly professionally, and to thank them also for that contribution that they bring through bringing that lived experience as well. Thanks, Tina. So the process so far, just a quick recap. We began with a face-to-face session with the lived experience participants, brought all 9 of them together, and we had, it was most of a day, a fantastic session there. Yeah, you'll start to see the incredible contributions they've already made in terms of both telling us what their experiences have been like or are currently like trying to access conventional supports while experiencing a suicidal crisis or supporting someone to do so, but also these great ideas, really creative ideas about how to meet some of the needs that are currently not being met by the ED and hospital system, and how the safe haven is hoping to meet. We then had what we call focus conversations, so small group conversations with health professionals as well. We had that feedback loop, which was on the same principles as this one, where we had a webinar and then a follow-up survey. And then we've recently had a health professional co-design session. So that was the whole group of health professionals bringing those together. And then now we're at the stage of this feedback loop today. And the purpose of this is to communicate the outputs of the co-design sessions so far, but also really importantly to gather that broader insight by getting community input from people who are not participating directly. We know particularly with co-design sessions that are sometimes held online, this one has been a mix, that it's very hard to get a lot of people in the room, and that we really need to hear from those missing voices to get a really diverse and broad range of perspectives, so that the service model is going to meet the needs of the most people in your local community. Thanks, Tina. Okay, just in terms of feedback from the feedback loop 1, we had 5 responses from people coming from the lived experience perspective and 1 health professional. Basically, there was agreement from the people with lived experience that the slides accurately reflected their experiences and the needs of a person in distress. Additional perspectives have been added to the list of ideas for the safe haven. You'll start to see some of those. Tina's going to take you through those in a moment, and that's you'll start to see where the ideas for that are coming out from people with lived experience map to the health professional perspectives and how they relate to the Ministry of Health requirements around these new services. But really what's happened through that feedback loop is it's starting to reinforce what the lived experience participants in the co-design sessions are telling us are their non-negotiables and priorities. We also received 1 response from a health professional, and that was some feedback around the co-design process itself. And we expect that will be I guess, addressed through just seeing this process as it continues. Hopefully the webinar will also provide some clarity, and then if you see, then that we'll talk about the next steps, and that will tell you actually how this process is developing. Thanks, Tina. So just a high level summary of the feedback. So lived experience respondents, as I said, agreed that the slides presented were accurately reflecting their experiences. One respondent noted the importance of recognising the difference between experiences pre and post COVID in terms of the hospital system. And one respondent noticed the importance of recognising the differences in the journey for someone experiencing crisis between ED and then an inpatient unit. So that is a different experience. We did manage to capture some of that difference in the earlier session. Lived experience respondents also agreed that the values outlined, which we'll take you through in a moment, did reflect what are the underlying values and principles that they hold, that they want the Safe Haven to hold itself to. And there were a couple more values suggested, including cultural competency and autonomy. So we've added those to the list of values that we'll be sharing with you in a moment. Thanks, Tina. We also asked a few targeted questions, and these questions were shaped directly out of that lived experience session. When we listened to some of the stuff that was coming out, we could see that what was quite important for people was to understand what the role of carers were in relation to the Safe Haven. How does the Safe Haven going to support carers? Everyone agreed that there is an important role that carers play in supporting people experiencing suicidal crisis, but what that looks like was something that is up for debate and is about sort of, it's part of the requirement of a local co-design process that local communities can shape that aspect of the model. So when we asked in the feedback in the survey, as a person with lived experience, what role do you think the Safe Haven should play in providing support to carers? There was mixed responses that we received, and they included someone saying that there should be a primary focus on the person who is suffering a crisis, and that in itself is what alleviates stress on carers. Someone said yes, support, extensive support for carers, providing links to support groups and respite care if needed. A primary focus on consumer in crisis, again, so that's what someone else had said, but offering support and some skills in parallel to carers and family, presenting on how best to deal with crisis situations. And then also another suggestion about offering a place where carers can go to access support and feel safe. And then we also had asked people around how to prioritise the ideas that were coming out of the lived experience participant session. And here are what the respondents noted as being the most important when we said, which of these ideas are the most important, and are there any other ideas you'd like to suggest? So peer workers checking in with people who are waiting so they feel validated in getting help, providing people with multiple avenues to express how they feel, verbal and written, providing a comfortable space, a private space with distractions available, TV, books, Wi-Fi, ability to access mental health professionals, a process for dealing with people who are aggressive, consistency of service opening hours. So there have been different suggestions. Everyone agreed that the blue sky ideal is 24/7 for a space like this, but recognition that there are organisational and funding constraints that make that not possible right now. Training and support for volunteers and staff if there are volunteers, digital access to wait time. So there was a suggestion around the idea that there could be an app that could tell you, or that you could receive a text if there were waiting times, and meaningful follow-up after someone leaves the Safe Haven. Thanks, Tina. And then a question as well that really was shaped by what we heard in that lived experience session around the need for culturally safe and responsive practice and care. For people experiencing suicidal crisis locally. What do you think locally appropriate, culturally safe practice could look like in the context of the Western Sydney Safe Haven? So that was the question we asked. Lived experience respondents noted the importance of having a diverse staff cohort working at the Safe Haven, including people from a range of cultural backgrounds, age groups, diverse sexualities and genders, and religions, culturally competent staff who are aware of sensitivities, so cultural sensitivities, and timely access to interpreters who are specifically trained and accredited in mental health. And then a final question, is there anything else you would like to share about your suggestions for the Safe Haven or your experience of the co-design process? And really it was summed up here: make it happen, advocate hard to increase from 2 peer workers and expand hours to 7 days. Thanks, Tina. Okay, so we're going to take you through the majority of this webinar is about to giving you summarising the outputs from that health professionals co-design session we just had recently, and how we've organised this. I'll get Tina to explain the structure, but it's around sort of key components of the local safe haven. Thanks, Tina. So these are the key components, the elements that are needing agreement. So values: what will the safe haven hold itself to? What values? Location of the safe haven: where will the safe haven be established? Connection pathways to and outward connections and partnerships. So how will people access the safe haven, and how will people be warmly connected to other supports if that's what they're wanting to do? The service model itself: what support will people receive at the safe haven? Staffing: who will deliver support? Workforce development: how will that staff, their capability be developed over time, and how will they be supported to be effective and sustainable as a workforce, as an innovative new workforce? Physical environment and accessibility: what does a safe haven look and feel like? How do people access it? And then governance, so that's sort of more high level questions around how will management of the service be reflected in clinical and operational governance structures, who will be involved? Thanks, Tina. And so just to set this up, we thought we'd just go through values first, because they are ones that have already been broadly defined through a statewide co-design forum that the Ministry of Health held in, I believe, 2019 now. And then what we did is we've actually pulled together some of the values and principles that we really tuned into in the lived experience session that sounded like they were quite common to people, to the participants, and what they want to see as the values that are really going to guide and underpin the way of working in the local safe haven. So the statewide ones, and you'll see they're not really just values, some of them are practice principles, but broadly we're calling them values. So the idea is that the safe haven should be person-centered in its approach, risk tolerant, non-judgmental, welcoming, responsive, compassionate, strengths focused, hopeful, holistic. Self-determination was a core value, empowerment, human connection, collaboration, integration, respect, evidence-based, dignity, inclusion, and choice. So they were some of the core values and practice principles. And you'll see some of the common themes emerging in terms of what we're hearing from lived experience participants locally in this co-design process. So privacy and confidentiality, respect, empathy, compassion, choice, nurturing and supportive, safety, listening, authenticity, transparency, reliability, timeliness, non-discriminatory, human connection again, collaboration again, and then we added these to cultural competency and autonomy that came back as feedback through the first survey. Thanks, Tina. Okay, so I might just hand it over to you, Tina, to explain the approach we're taking as part of our process, and then take people through what we've explored.
Okay, thanks, Carrie. So what we're going to do now is we're going to have a look at the ideas that have been put forward by people with lived experience in Western Sydney. And we're going to look at how they match up with what the Ministry of Health expects for the safe havens. And also we're going to look at the ideas that have been raised by health professionals. We're going to present them side by side, and we're going to use colour coding on the suggestions. So everything that you see in green is an idea that is consistent with the Ministry of Health guidelines, and also where you have consistency with what health professionals and people with lived experience would like to see. If an idea is being raised by participants with lived experience or by health professionals that needs further discussion and exploration, we've put it in orange, and there could be a number of reasons why it's been put in orange. It may be that it's a new idea that hasn't been explored and that we just need a little bit more information about what it is that people would like to see. It could be that it's a suggestion where there perhaps need to be further decisions made about how that could be achieved and still be consistent with the Ministry of Health guidelines. Or it could be that it's something that is going to be difficult to achieve with the practical parameters of what can be done with the safe haven. And so there needs to be further discussion around how that might actually be implemented with the resources that are available. So all of those areas that require further discussion are going to be in orange. And some of the ideas you'll see are in red text. If it's in red, it means that it's out of scope due to the Ministry of Health guidelines. There are some decisions that have already been made by Western Sydney LHD about the safe haven, and those decisions are not reflected in the out of scope. It's specifically the ideas that are out of scope with the Ministry of Health guidelines. That may be because there's been a clear directive that something to the contrary happen. Or it may be that with the resources that are available, that it's something that can't currently be achieved. So as we take you through these slides, you're going to notice that there's a huge amount of information. What I encourage you to do is to, if you're watching the recording of this webinar, to pause the recording when we get to the slide, because what I'm going to focus on will be the sections that require further discussion that are in orange, and also the out of scope ideas which are in red. But you can read all of the ideas, including all of the ideas that are in green, just by pausing the recording. Or if you're watching this live, the other option is that we are printing up all of the slides and they're in the survey that there'll be a link to at the end of this webinar. So you'll be able to read through the full range of ideas when you open up that survey. So the first thing that we look at in co-design is the location of the safe haven. There have already been some decisions made, and that they're looking into a particular site in Westmead for the safe haven, but we still like to capture people's ideas about where the service should be located and how close the service should be to the emergency department. So as you can see here, we've got the Ministry of Health requirements on the left, and they say that the service needs to be located on or off hospital grounds, but within proximity of the emergency department. So people shouldn't have to travel too far to get to the safe haven. And you can see that we've got two areas for further discussion here. So one of them is the lived experience co-design suggestion that there actually be multiple sites, that there be lots of small safe havens located throughout the LHD so that they're easily accessible to everyone. So that's in orange because it would require exploration as to how that could be achieved within the resources available. But in the health professional discussions, there was some concern about whether this was achievable. But there was a suggestion from one participant that multiple satellite sites could be set up for the safe haven, where there's a staff member at a different site who is able to direct guests to the safe haven. The next thing we talked about with health professionals were connection pathways to and from the safe space. And some of the questions that we are looking at here is, how will the service be promoted in the community? How will it be promoted in other health services and also in community organisations? Also, we looked at the question, what support does the district need from the ministry around communication and promotion, and what partnerships will support local connections to and from services for the guests of the safe space. And those connections to and from the safe space were a real focus in the conversations we had with health professionals. Also, what arrangements and protocols will be put in place to support connection to and from the emergency department if that's what people want to happen. So again, you can see that there's a lot that you can read through here. If you pause the webinar, there's a huge number of ideas around the connection pathways. I'm just going to highlight the things that we do need to get some more information from people with lived experience and from health professionals on. So a big one is the idea of no police involvement. And there was some discussion with the health professionals about the need for police involvement. So we need to explore if there is a way that we can achieve what people with lived experience feel they need in a way that health professionals are also supportive. The idea that people will be able to access wait times online. This is a very unique idea to Western Sydney LHD. It's something that we'd need to talk about more about how this would work. People waiting to see the safe haven would receive a text message to let them know when they're ready. So there was some conversation with health professionals around what might be required in order to set up a system like this. The idea of around what should happen if somebody approaches a safe haven and they're intoxicated or they're aggressive is something that's come up for strong discussion in both with people with lived experience and with health professionals in Western Sydney. So the lived experience perspective was that people who are highly intoxicated or aggressive need to be welcomed to the safe space and need to be made to feel welcome, but need to be asked to or encouraged to attend the following day. There was an alternative perspective with health professionals. That was that people who are highly intoxicated or aggressive should be referred to the community mental health team for transport, or if it's unsafe for them to leave the premises, to call the ambulance or the police. So you can see that there are different perspectives on this, and that will need to be explored. People with lived experience would like to see no paperwork for people who are accessing the safe haven. Again, this has raised some different perspectives with health professionals who feel that a certain amount of information will need to be collected for duty of care reasons. And people with lived experience feel that going there should never be on involuntary terms. And so we just need to explore what that means. Health professionals also raise the idea that there should be de-escalation and accessing of natural support networks if that's possible and appropriate when people are highly intoxicated or aggressive. So we'll explore these questions in more depth when we get to the combined session where health professionals and people with lived experience in Western Sydney will all come together for a joint session to have these important conversations. So in terms of connection pathways to and from the safe space, there's a number of questions that need to be answered in relation to this. So how will the service be promoted in the community? Well, sorry, I've gone backwards. My apologies. So before we were talking about people connecting to the safe haven and how that might happen. Now we're having a look at ideas that people have around where people will go after they leave the safe haven and who the safe haven will connect people to. Again, there's a lot of ideas that are completely consistent with Ministry of Health guidelines and show agreement between people with lived experience and health professionals. They're in green, and we encourage you to pause the webinar and have a read over those. Just to highlight, there are a number of ideas from people who have lived experience of suicide in Western Sydney that we will need to explore further. So again, that idea of not having any police involvement. They would like to see follow-up with people after they leave the safe haven, and we would just like a little more information around what that follow-up would involve. Also, access to free mental health professionals for ongoing support. And so that's another thing that can be explored in terms of what processes could be set up for that. The need for meaningful support and follow-up after leaving the service is something that people with lived experience have talked about quite a lot. So they're seeking something different to the way that it's currently done when they leave after visiting the emergency department or receiving treatment following a suicidal crisis. There was also an idea raised that the safe haven could be a place that provides education for the community, for police, for health professionals, and for schools about mental illness. And this idea of the safe haven being a provider of education is it's not something that was really considered by the Ministry of Health when they were setting their guidelines. So we'd just like to explore exactly what that would involve in a little more detail. In terms of the service model, so the big question here is the one that Carrie referred to earlier, which is how guests, carers, family and friends will be supported. And that's something that we've heard quite a bit now from people with lived experience on this. It'd be good to hear from health professionals in particular in the survey about their views on this issue. So again, you can see lots of ideas there that are definitely quite achievable and consistent with the Ministry of Health guidelines for the service model. Just some things we'd like to speak about and get a bit more information on. It includes the idea that people receive immediate support and that there's always somebody available to talk. We'd need to explore how that might be achievable with the current staffing of 2 full-time peer workers. Also, people with lived experience said people can decide and determine their own level of distress. So we'd need to talk about that with both people with lived experience and health professionals because the health professionals that have expressed a fairly strong view that there needs to be assessment and that's inconsistent with people determining their own level of distress. So we need to see if we can find a way that that people with lived experience can be comfortable with those processes and that health professionals can be confident in what's happening in the safe haven as well. The idea of self-help workshops and group therapy is again something that wasn't really envisioned by the Ministry of Health, and it would be good to get a little bit more information from people about what might be offered in that regard and how that might be offered. And it was good to hear too, again, something that was raised in Western Sydney that is fairly unique to Western Sydney. And that's the idea that the safe haven could be a place where people can seek pastoral and spiritual care. That's something that we talked about with health professionals and definitely I'd say there's an openness to that. But it would be good to explore exactly how that's going to be provided. Some ideas that health professionals raised that we would like to talk about more include that issue of the police and involvement. It was expressed that there may be times where due to duty of care reasons, the police might need to become involved. The health professionals were again open to the idea of group therapies being provided in the safe havens. So it'd be good to see in the joint conversations how that can be fleshed out a little. Health professionals raise the idea that there needs to be a threshold for support, and this is something that we certainly haven't spoken about with people with lived experience. So that the idea that that the people who staff, the peer workers who are staffing the safe haven might be able to provide support for people up to a particular point, but that people whose needs go beyond that point, that there needs to be recognition that that's then outside what the safe haven can respond to, and that they know how to connect that person with other services or the emergency department. So this idea of follow-up also came up with health professionals. So what was suggested by health professionals was that there be medium to long-term follow-up after people visit the safe haven. There were a couple of ideas that are inconsistent with the Ministry of Health guidelines for the safe haven, and that's why we've put them in red. There might be ways, if we talk about it, that these ideas can be brought within scope. So one is that there should be a robust clinical assessment process. The guidelines for the safe haven say that people shouldn't need to be assessed in order to access the safe haven, and that the safe haven will not involve any clinical support or clinical practices, that it's a non-clinical space. So at the moment, the idea of robust clinical assessment processes does appear to be inconsistent with those guidelines. Also, that there should be clinical parameters in place that allow for referral to the emergency department. So again, we need to look at the role of clinical practices in those referral processes, and that there might be a way to achieve what people are looking to achieve here. That, you know, if we have further conversations, there may be a way for that to be achieved within the Ministry of Health guidelines. So in terms of staffing for this, the safe haven, this is something that the people with lived experience of suicide in Western Sydney have provided us quite a bit of information on, but we would like to have further conversations to get more of the health professional perspective on staffing. You can see again, there's a lot of ideas in green that you can read through if you pause the webinar. Some things that we need to have further conversation about. So there was an idea that there should be a dedicated worker for each person so that there's continuity in the support that people receive. Again, we would need to look at how this could be achieved within the current staffing model of 2 full-time peer workers. Also, people with lived experience raised the possibility of the safe haven not just involving suicide prevention peer workers, but also involving social workers and occupational therapists. And so this is an interesting idea. It also raises the question, what does clinical mean? And that's something that there's a lot of debate about. So it'll be good to explore whether that's something that can be achieved. Something that was raised by the people with lived experience was the idea that the staffing limitations might be able to be overcome by having volunteers working in the safe haven. So the words that we used were that there could be an alumni style cohort who kind of drop in and talk to people. So people who have previously been guests at the safe haven, who pop back in every now and then and have a chat with the new guests. It was also suggested that there could be a volunteer network of people who, you know, have previously had some experience. It was made clear that they felt that everyone, including volunteers, should be receiving the training that they need to do that. So there was some concern with health professionals about involving lived experience volunteers in the safe haven. In particular, concern that having volunteers working in the safe haven may undermine the legitimacy and importance of paid peer workers. So this is something definitely that we need to have further conversations with both people with lived experience and health professionals about. So some issues that can be considered, some questions that we need answered. what's going to be the staffing model with the allocation of 2 full-time SPP workers, and what support is required for the SPP workforce. And on this matter of workforce development and support, it is something we need to have further conversations. But as you can see at the moment, all of the ideas that have been put forward are consistent with the Ministry of Health guidelines, and there's also consistency between what people with lived experience are asking for and what health professionals need to feel comfortable with the safe haven. In terms of physical environment and accessibility, some of the questions that we're looking to answer are: what will be the opening hours? And what will the style of the service be? Will it be a cafe, a lounge? Will there be meeting rooms? Is there something else that people think will work? How will the service specifically address the needs of priority groups? So the needs of Aboriginal and Torres Strait Islander people, the needs of people from the LGBTQI plus community, the needs of men who we know are at high risk, and also the needs of young people and older people. So it'd be good to get some ideas around, it's been really highlighted in Western Sydney that cultural safety is quite important for people who are going to be accessing the safe space. So the physical environment is something that we've spoken about quite a bit with people with lived experience. We haven't had the opportunity to really explore this with health professionals yet, but you can see there's lots of ideas there that that are quite consistent with the Ministry of Health guidelines. Things we'd like to talk about more, the idea that there'd be a therapy animal and a fish tank, and how's that going to work in a safe haven that is going to have, I guess, set hours when it's open. Ideal hours of 24/7. People with lived experience realise that at the moment this is not possible, but they think that in the long term that's a good goal. They said that otherwise the hours should cover the evenings and early mornings. It was when people with lived experience felt that people would be at greatest need of using and accessing the support in the safe haven. And also the idea that it should be the same opening hours each day to help with consistency, just so that people know exactly when that support is available. So the last thing we look at is governance. And definitely this is an area that needs greater exploration with both the groups, the people who have lived experience of suicide and also with health professionals. We haven't really managed to, the conversations haven't brought up a lot of information about this yet. So some of the things that we're interested in hearing about are how will management of the service be reflected in clinical and operational governance structures of the district? What is the key risk in establishing the service, and how will this be managed? What arrangements and protocols will be put in place to support referrals to and from the emergency department? And also, how will people have the opportunity to provide feedback on the service, and how will outcome data be collected and reported? So at this point in time, the only ideas that have come up in the conversation relating to governance have been things that will require further exploration. So in particular, the people with lived experience would like to see no paperwork involved in accessing the safe haven. However, it has been made clear by the health professional participants in this process that they think there should be mandatory collection of data and contact details. So this is something that we will have further conversations with everyone about in the combined session that's coming up next.
Thanks, Tina. I know that's a lot of information to get through, and as you said, people are welcome to go back, because this is recorded, and look at it at their leisure, or sort of dig into the detail of it in the survey. All the slides will be embedded there, and that is actually what we really are going to ask you to do now. Please take the time to complete the survey. It doesn't have to take a long time. But what's really important is that you spread the word about this. We know that for co-design, that it's really important if you're developing services that are going to be effective and sustainable, that you need the greatest diversity of voices in these co-design processes. The limitations are just there around how many people can directly participate, which is why we do the process we do of having a number of feedback loops. We hear how passionate local community members are about making sure that all of those voices are present. And the way to do that is to tap into your own formal and informal networks, get this link out there to people, encourage them to do the survey. We want to hear their input. As you've heard Tina taking you through, that what's emerging here is how important the principles of cultural safety and responsiveness are, and that is because there's so much diversity in these local communities, and we do need to hear from people with those perspectives and that expertise. So this survey is open now after this webinar, and then it closes on the 23rd of May. We then next week have that combined session. It's a half-day face-to-face session with people with lived experience that have been participating directly and health professionals. We bring them together. They work in equal partnership to further explore, as Tina said, some of those key areas that she's been talking about today. One of the key ways we do that is to get them to work through together, to work through some real world scenarios that the local safe haven are likely to encounter, particularly ones where people might really test the values and principles around it being a non-clinical peer-led service that's very risk tolerant, and get people to work through that and to see how they can maybe come to some agreement, maybe creatively resolve some of those tensions and points of divergence, so that the local safe haven is really holding to the values and principles, not just the general ones provided by the ministry, the ones that are emerging here locally about this local safe haven and how it's going to meet the needs and wants of the people experiencing emotional pain and distress, that where ED and hospital is not the best fit for them in those circumstances. And what is this model going to be able to achieve in terms of meeting the current unmet needs? It's really important that we get as many people in the local community to get involved in this process. We know that there are a few people watching live. Just wanted to check to see if anyone had any burning questions they wanted to ask here. Otherwise, please put your feedback, any questions you have there, you can put them into the survey when you respond, and have a look at some of those questions and issues for further exploration. Please feel free to have your say then, and also to bring some of your bright ideas next week if you're participating in that session. We're really looking forward to seeing everyone come together and do that. It's very valuable for people with lived experience and health professionals to come together in this way that have been contributing so far. So if there are no questions right now, just wanted to say thanks very much for people for taking the time to look at the webinar. Spread the word, as we always say, and thank you for listening, and have a great day.